Good morning, friends. In this talk, I'll be discussing the less common forms of vertical canal BPPV. This is the part one of my talk, which will be delivered today. And in this, I will be discussing the short-term posterior semicircular canalolithiasis, posterior semicircular cupulolithiasis in the part A. And in the part two, I will discuss the periampullary-restricted posterior semicircular canalolithiasis with partial canalith jam, that is the Scocco 2019 variant. The left membranous labyrinth of this gentleman is shown here. Painted in the red is the short arm of the left posterior semicircular canal. Painted in the green is the portion of the long arm of the posterior semicircular canal, and painted in the pink is the portion of the non-ampullary arm of the long arm of the posterior semicircular canal. The otoconal debris, it resides in the recessus ellipticus, which is a transversely oval depression in the vestibule's roof, which is located in the central part of the bony labyrinth, that is the inner ear, and it houses utricle and saccule that detects linear acceleration and gravity. It is separated, that is divided from the spherical recess, that is the saccule area, by the vestibular crest, which is a small bony ridge. Otoconal debris, it dislocates from the utricular macula in the recessus epilepticus and usually reaches the periampullary region because of its gravity dependent position, resulting in the periampullary typical posterior semicircular canalolithiasis that we treat with the Apley or the Semont maneuver. However, sometimes the otoconal debris, it gets entangled in the non-ampullary arm near the crus commune, leading to apogeotropic posterior semicircular canal BPPV that was first described by Agus in year 1995 and in detail by Vanucci in year 2015. However, since 2015, two more variants of the apogeotropic posterior semicircular canal BPPV have been recognized in 2020. Shigeno also found a non-ampullary variant of the posterior semicircular canalolithiasis, but in those cases they had a reversal nystagmus which was not present in the cases described by the Vanucci et al. And another variant is the periampullary variant that changes into the typical variant by neck extension during the Dix-Hallpike maneuver. That will be discussed in the part 2 of my talk. So the otoconal debris that you see here in the utricular macula can fall directly into the short arm, resulting in the short arm posterior semicircular canalolithiasis. However, it has been associated with the early retest. So presumably, when we treat the typical periampullary posterior semicircular canalolithiasis by the Apley or Semont maneuver, the otoconal debris, instead of getting embedded into the utricular macula, slips off and reaches the short arm, that's shown by animation here, and that's how it is causing the residual dizziness in patients whom you think you have treated successfully with the Apley maneuver or Semont maneuver. So, what are the various subtypes of the posterior semicircular canal BPPV? The typical periampullary posterior semicircular canalolithiasis is here, which is the most common, and I will not be discussing here because every day and night we have been treating this variant with the Apley or Semont maneuver, and this is not the topic of discussion today. The second is posterior non-ampullary arm semicircular canalolithiasis, and that is called the apogeotropic variant. The apogeotropic variant has been recently found to have 3 variants, and that will be discussed in part 2 of my talk. The third is cupulolithiasis, the heavy cupula, which could be because of the cupulolithiasis on the short arm side or on the long arm side. The fourth one is short arm posterior semicircular canalolithiasis. We will be discussing this in detail in the part A of this talk. And finally, there is a periampullary restricted posterior semicircular canalolithiasis with partial canalith jam, which is called the Scocco 2019 variant. This is the part B of this talk. Next 5 slides I have taken deliberately because of the benign paroxysmal positional diagnostic criteria which were released by Berlin Society in the year 2015. Berlin Society criteria for posterior semicircular cupulolithiasis are clinically useful, but I am very sorry to say that they are not universally encompassing. Why? We will discuss in the case 2 of this talk. Cupulolithiasis of the posterior semicircular canal (BPPV) of the posterior semicircular canal due to cupulolithiasis. Criteria A: recurrent attacks of positional vertigo or positional dizziness provoked by lying down or turning over in the supine position. B: positional nystagmus elicited after brief or no latency by half Dix-Hallpike test. That is a problem because it can be elicited also by the Dix-Hallpike test. Why it is not added here? Beating torsionally with the upper pole of the eye to the lower ear and vertically upwards to the forehead and lasting more than 1 minute. Again, this is a problem. We do agree that the posterior semicircular cupulolithiasis evokes a persistent nystagmus which lasts more than 1 minute. But such a nystagmus in the recent times in year 2022 has been described to be seen or evoked by the half Dix-Hallpike test in patients with short-term posterior semicircular canalolithiasis, not attributable to another disorder. So our biggest red flag is the non-inclusion of inversion test that differentiates a persistent upbeating ipsitorsional nystagmus evoked during the half Dix-Hallpike test, whether it is resulting from cupulolithiasis or from the short-term posterior semicircular canalolithiasis. The concept of this inversion test is not new. In the year 2001, even when the short-term posterior semicircular canalolithiasis was very less known at that time, what did the great John M. Apley said about this? What did he say? Each posterior cupula has two potential provocative positions oriented 180 degrees to each other. Earthward direction in one position is excitatory and in the other position inhibitory. If the particles are adherent to the cupula, persistent nystagmus will occur in both positions in the same plane but will reverse direction when the head is turned through 180 degree. Identification of this nystagmus reversal with head inversion confirms the presence of cupulolithiasis. If persistent nystagmus maximizes in one provocative position but does not occur in the inverse position, it suggests that the cupulolithiasis may be present due to non-adherent particles falling away from cupula in one of these positions, but in that case the diagnosis is less certain. It was almost 21 years later Darius Scocco published this paper setting up vertigo as an expression of posterior semicircular canal heavy cupula and posterior semicircular canal short-term canalolithiasis, in which he mentioned the inversion test which was negative in patients with posterior semicircular canalolithiasis of the short-term type and it was positive in patients with posterior semicircular cupulolithiasis. It is another point to be noted here in the same article by the John Apley of 2001. The particles are apparently adherent, that is, they reside on the upper side of the cupula when the head is in half Hallpike position, in which case the particles will usually be most easily dislodged in the release position. According to the John Apley, the release position is the position 2 of the Simon maneuver, that is the third position of the Apley maneuver, that is contralateral recumbent, that is to the non-involved side with the nose down. So he means that the cupulolithiasis is mostly on the short arm side. That was his perception 25 years back. So I begin the part 1 of my A of my talk. The short arm of the posterior semicircular canal, as we see here, the otoconal debris, it can detach from the utricular macula and fall directly into the short arm and leading to the short arm posterior semicircular canalolithiasis, which was first described in detail as type 2 BPPV or subjective BPPV by Buki et al. In 2011. According to them, they did not observe any oculomotor responses during the Dix-Hallpike testing. However, on getting up from the Dix-Hallpike test and during natural course, they found that patient complained of truncal oscillations and there was retropulsion, and they in fact demonstrated the truncal oscillations by an ad hoc posturography conducted during the Dix-Hallpike test as the patient was uprighted from the Dix-Hallpike test. That was the concept, that is the BPPV without nystagmus. When it remains in the short arm for a long time, it results in cupulolithiasis, which the Hermat 2022 says it a short arm posterior semicircular cupulolithiasis. However, we do not have to comment too much on the short arm or the long arm side posterior cupulolithiasis, because the cupulolithiasis either on the short or on the long arm side will produce the identical oculomotor responses during the positional test, and adding the adjective like short arm side posterior semicircular cupulolithiasis only increases the confusion. So, pathogenesis of the typical posterior semicircular canalolithiasis, revising again, the otoconal debris in the utricular macula gets detached and reaches the periampullary location because of its gravity dependent position. And this is repositioned back by the apply or the surmount maneuver like this. However, sometimes during the repositioning, the otoconal debris, it slips off from the utricular macula and reaches the short arm, resulting in short arm posterior semicircular canalolithiasis, and this has been demonstrated by Scocco in his patients who observed short arm posterior semicircular canalolithiasis in patients with early retests. That is, the patients were treated for the typical posterior semicircular canalolithiasis at his center or elsewhere, and they had a residual dizziness in the form of sitting up vertigo. So, what does the research so far says about the short-term posterior semicircular canalolithiasis? It was Oz in year 2001 who said that the Dix-Hallpike test cannot differentiate the long arm from the short arm posterior semicircular canalolithiasis. However, he noted that the absence of reversal nystagmus on sitting from Dix-Hallpike test and the absence of orthotropic nystagmus or presence of downbeat nystagmus during the step 2 of the apply maneuver suggests short arm posterior semicircular canalolithiasis. He did not have more descriptions about this disorder at that time. In year 2011, Buki found that vertigo spells occur during and after sitting up with anterior posterior truncal retropulsion treated with the multiple sit-ups from the lateralized Dix-Hallpike position. Tora, a Chinese author in the same year 2011, found that DST, they had a typical BPPV, but it was persistent nystagmus lasting more than 60 seconds. There was no reversal nystagmus and it was unresponsive to apply maneuver. However, it responded to temporal bone vibrations in the lateral recumbent position with the involved ear up. Scocco in year 2022 described sitting up vertigo upbeating ipsitorsional nystagmus on sitting up from the Dix-Hallpike test, persistent upbeating ipsitorsional nystagmus during the half Dix-Hallpike test, and in 11 out of 18 patients, possibly ipsicanal cupulolithiasis was present. This is an interesting study from South China of 2022. In 40 out of 171 patients in whom the Dix-Hallpike test elicited upbeating ipsitorsional nystagmus, responded to the bow and yaw maneuver alone. Rest responded to apply maneuver. So, according to this study, as many as 38 to 40% of patients who look identical to the typical periampullary posterior semicircular canalolithiasis might be because of short arm posterior semicircular canalolithiasis, because they did not required any apply maneuver once they were treated with bow and yaw maneuver. In our own series, 2 out of 9 patients only had posterior semicircular canalolithiasis of the short arm type. 4 out of 9 had only posterior semicircular cupulolithiasis. 2 out of 9 had the short arm posterior semicircular cupulolithiasis with short arm posterior semicircular canalolithiasis, and 1 out of the 9 patient had a combined long arm plus short arm posterior semicircular canalolithiasis. Helminski in 2024, he says that the short arm posterior semicircular canalolithiasis is similar to that of our series and that of Scocco 2022. However, he adds the term short arm posterior side cupulolithiasis, which we don't want to include because it creates the confusion with short arm posterior semicircular canalolithiasis. So cupulolithiasis, whether on the short or on the long arm side, will produce the identical oculomotor patterns depending on the shape of the posterior cupula and not dependent on the side to which it is adherent, that is the long or the short arm side. So the diagnostic maneuvers and repositioning of the short arm posterior semicircular canal BPPV. This slide I have seen here because the posterior cupula is parallel to the Earth's gravity in the Dix-Hallpike position. So in the short arm posterior semicircular canalolithiasis, there is no positional nystagmus. However, in the half Dix-Hallpike test, the posterior cupula is orthogonal to the Earth's gravity, and the orthogonal debris which are on the short arm side, they press upon the cupula from the short arm side, resulting in the upbeating ipsitorsional positional nystagmus. So the optimal test for evaluating patients for the short arm posterior semicircular canalolithiasis is the half Dix-Hallpike test, and it is not the Dix-Hallpike test. So this is our first case, residual dizziness after a possibly autocorrected horizontal semicircular canal BPPV. This is a 62-year-old male came with a history of severe vertigo, vomiting, and significant nausea and other vegetative symptoms for 2 days. And on day 3, he comes to me with vertigo, which was mainly sitting up, and he had a tendency to fall backwards on getting up out of the bed. The left Dix-Hallpike test during 1 minute of observation did not evoke any positional nystagmus. We maintained the head hanging left Dix-Hallpike position for full 1 minute. So it is a routine protocol in our clinic to maintain the Dix-Hallpike position for full 1 minute to observe the nystagmus, and if it is present or not present. If it is present and lasts more than 60 seconds, then we do a inversion test, that is the right lateral recumbent with nose down in this case. And if it is absent, then we anti-flex the cervical spine around 60 degrees to bring the head 30 degrees above the horizon and thus augmenting it to the half Dix-Hallpike position. The half Dix-Hallpike test with augmentation evokes a left torsional upbeating positional nystagmus. That you see right now on your screen. So as soon as the nystagmus lasts for more than 60 seconds, it is labeled as persistent upbeating left torsional positional nystagmus, and in this case it could be either because of the cupulolithiasis of the left posterior semicircular canal or short arm posterior semicircular canalolithiasis. So what to be done next, which is not prescribed or seen in the recommendations of the Barani Society criteria, is the inversion test. In this case, from the left half Dix-Hallpike position to right lateral recumbent with nose down, the nystagmus disappears. So the inversion test is negative. So it is predictably because of left short arm posterior semicircular canalolithiasis. Possibly the left horizontal semicircular canalolithiasis got auto-corrected. It gets auto-corrected even by sleeping to the non-involved side for one night or even for 1 hour. However, the otoconal debris did not get embedded into the utricular macula and reached the short arm, which is in direct communication with the utricle. So this is an adapted form of the bow and yaw maneuver, first described by Ping in 2022, with the head out of the short edge of the examination table and the vertex oriented towards the earth. The head is shaken at 3 cycles per second with the lateral excursions of 30 degrees for 1 minute. The idea is to move the otoconal debris in the short arm, which is a narrow tract, towards the utricle under the influence of gravity. It is just like removing the ketchup adherent on the inner surface of the ketchup bottle by inverting the bottle on the table and then shaking it side to side. So after carrying out the head shaking, static positioning for 1 minute with the vertex oriented towards the earth is essential. Why this is essential? Because if the head shaking is continued unabated, the otoconal debris will keep on moving within the utricle and it won't get embedded into the utricular macula. So once you have presumably shifted the otoconal debris from the short arm into the utricle, it is essential to stop the head shaking and just keep the head with the vertex oriented towards the earth for another 1 minute. So this is a 2 minute maneuver, the prone pitch and yaw maneuver. We call it an adapted prone pitch and yaw maneuver, and this was first adapted by the Srinivas Dorasala from Bangalore, and that's why we call it a Dorasala prone pitch and yaw maneuver. The patient was re-examined a day later with the left Dix-Hallpike retest, which was negative, and it should be negative because we are dealing with the short arm posterior semicircular canalolithiasis, not the typical periampullary posterior semicircular canalolithiasis. So maintained the position for full 1 minute. Patient did not evoke any nystagmus. More important was to augment it by antiflexing the head 60 degrees so that the head is 30 degrees above the horizon and thus making it a half Dix-Hallpike test with augmentation. After observing no nystagmus in the left Dix-Hallpike head hanging position, we anti-flex the cervical spine around 60 degrees and the head is now 30 degrees above the horizon. No nystagmus was evoked. Patient was asymptomatic at the time of testing and it is almost a year now. He continues to remain asymptomatic. He was telephonically interviewed for 4 weeks and was given an open appointment as soon as the vertigo occurs. So our diagnosis is a possibly auto-corrected left horizontal semicircular canalolithiasis that presented to us with residual dizziness, and the cause of residual dizziness was decoded to be because of left short arm posterior semicircular canalolithiasis. So this patient teaches us that in cases of residual dizziness, when you don't find a positive Dix-Hallpike test, it is always mandatory to carry a half Dix-Hallpike test with augmentation. Case 2 is a very interesting case of otoconal odyssey from posterior semicircular cupulolithiasis of the right side to the typical right periampullary posterior semicircular canalolithiasis after the Bascule maneuver, and finally when the typical posterior semicircular canalolithiasis was treated with the Applet maneuver, it resulted in residual sitting up vertigo that was decoded to be because of short arm posterior semicircular canalolithiasis. This is a 64-year-old hypertensive female seen in the third week of March 2026 with vertigo on getting up from supine and on transitioning to right lateral recumbency. There was no history of walking difficulties or carrying out activities of daily living with the upper limbs. BP was 130 by 80 in the supine position with no postural drop at 1 and 3 minutes. Gaze holding, smooth pursuit, saccadic eye movements were normal. Power was 5 by 5 in all four limbs, and there was no appendicular or gated axia. Initial Dix-Hallpike test, which I have not shown here, as well as the half Dix-Hallpike test, evoke without any latency an upbeat right torsional positional nystagmus. With the head rotated 45 degrees to the right, the head lands on a 3-inch thick pillow, thus anti-flexing it 30 degrees and making it a half Dix-Hallpike test. It evokes a right torsional upbeating positional nystagmus. We need to observe the positional nystagmus for full 60 seconds to classify this as persistent. And once 60 seconds have elapsed, it would be mandatory to do a inversion test, that is in this case the transitioning the patient to left lateral recumbent with nose down. If the nystagmus vectors both torsional as well as vertical, the reverse direction, it is likely to be because of cupulolithiasis of the right posterior semicircular canal. Right now we are seeing right torsional upbeating positional nystagmus. So after 1 minute of observation, we transition the patient to left lateral recumbent with nose oriented downwards. This is in line with the Applet's recommendation of 2001. The nystagmus reverses direction, it becomes downbeating and left torsional. The upper corneal poles of both eyes are torsionally beating to the patient's left in the nose down position. So the right posterior semicircular cupulolithiasis was confirmed. We carried out the Bascule maneuver, which was first reported by Andrea Casplusi in August 2025, and in that publication I was a second co-author. For the Bascule maneuver, the patient is seated in short sitting. The head is rotated 45 degrees to the non-involved left side and taken briskly to the face down position, left lateral recumbent with face down for 15 seconds. After that, the patient's head and torso is en bloc position to right lateral recumbent with face up. So we carried out such transitions which can be technically termed as reverse Simont and Simont maneuvers done in quick successions. The nose down or the face down position to her non-involved left side and the face up position with right lateral recumbency to her involved right side. What is the scientific basis of carrying out the Bascule maneuver? By moving the patient head in the LARP plane The LARP is abbreviated for left anterior and right posterior canal plane. We are generating the inertial forces, and inertial forces generated are presumed to detach the otoconal debris, which is adherent on the right posterior cupula, either on its short arm or long arm side. If it is on the short arm side, it is likely to get corrected by this maneuver directly. And if the debris is adherent on the long arm side of the right posterior cupula, with this maneuver, if it gets detached and disengaged, it's likely to get converted into typical periampullary posterior semicircular canalolithiasis. So we carried out the face up and face down positionings 5 to 6 times on each side, and next day the oculomotor responses were suggestive of typical periampullary right posterior semicircular canalolithiasis that I'll be showing after a diagram showing how the Bascule maneuver works. So this is the otoconal debris here, which is attached on the long arm side of the right posterior semicircular cupula. The first position is A here. Nothing much occurs, but the otoconal debris is still being affected by the shear forces or the inertial forces generated in the LARP plane. In the position B, that is the reverse Simard motioning, at some part the otoconal debris it got disengaged and reaches the lowest part of the right posterior semicircular canal, and thus converting it to canalolithiasis. And as the patient is taken back to the upright sitting position, the otoconal debris moves to the periampullary location, converting into the typical right posterior semicircular periampullary canalolithiasis. So the right Dix-Hallpike test, which was done 24 hours after the Bascule maneuver, shows the initial crescendo decrescendo right torsional upbeating positional nystagmus lasting 20 seconds, so it is non-persistent and suggesting right posterior semicircular canalolithiasis. There is a catch here. After 20 seconds, the nystagmus reverses its direction. It becomes downbeating, left torsional, and slow crescendo decrescendo lasting around 40 seconds. So this is nothing usual. It is still right-sided periampullary posterior semicircular canalolithiasis. The direction reversal is because of the short-term adaptation of vestibulo-ocular reflex, which is called the short-term central adaptation of the vestibulo-ocular reflex, where the initial phase of the nystagmus is short and the direction reversal phase is usually longer. Uprighting from the right Dix-Hallpike test, that is the retest done 24 hours after the Bascule maneuver, also evoked reversal nystagmus, that is downbeating and left torsional. Right applied maneuver was carried out. The patient returns on the day 3 and we carried out the right Dix-Hallpike retest. On day 3, the main symptoms were sitting up vertigo and truncal retropulsion. We carried out the right Dix-Hallpike test. During 1 minute of head hanging in the right Dix-Hallpike position, no nystagmus was evoked. Even during retesting, it is mandatory to maintain the head hanging position for full 1 minute, because sometimes the nystagmus latency is as long as 40 seconds, and according to one study case report, it has been found to be as long as 5 minutes. So we cannot wait for 5 minutes, that is only a single case report, but up to 40 seconds even has been observed by me in my clinical practice. So again, as the protocol is there in our clinic, after 1 minute of a negative right Dix-Hallpike test, we anti-flex the cervical spine 30 degrees above the horizon. The sitting from the right Dix-Hallpike test now evokes a right torsional upbeating positional nystagmus. And this is persistent, lasting full 1 minute. The first Dix-Hallpike test on day 1 of consultation was also identical, but was in the right Dix-Hallpike head hanging position. And now, after treating patients consecutively for 2 days, first with the Bascule maneuver and then with the right Applet maneuver, the patient is free of most of her symptoms except for setting up vertigo, and now we see a negative Dix-Hallpike test, but setting from the right Dix-Hallpike test evokes a persistent right torsional upbeating positional nystagmus, and this has been reported by the Darius Scocco in year 2022. However, we carried out a half Dix-Hallpike test with augmentation also. The patient was taken to the right Dix-Hallpike head hanging position, maintained in this position for full 1 minute. We could not observe any nystagmus as we had seen in the previous video also, but this time we repeated it to carry out a augmented half Dix-Hallpike test, which should be positive in case of short-term posterior semicircular canalolithiasis as it looks like. Maintaining the right Dix-Hallpike position for 1 minute did not evoke any nystagmus. So as soon as the 1 minute was over, we anti-flexed the cervical spine about 60 degrees to make the head lie 30 degree above the horizon, and thus making it an augmented half Dix-Hallpike test. And you can now see that immediately there is a right torsional upbeating positional nystagmus. We observed this nystagmus for full 1 minute, and if 1 minute persistent nystagmus is observed in the right half Dix-Hallpike position, augmented in this case, the next thing to be done is inversion test. That is transitioning the patient to left lateral recumbent with nose oriented down. If this nystagmus disappears, it's likely because of the free floating otogonia in the short arm side of the right posterior cupula, which are now pressing the cupula from its upper side surface and generating a excitatory oculomotor response. In the inversion position, the nystagmus disappears. We observed this for a quite long time, and she did not evoke any nystagmus. So the diagnosis of right short-term posterior semicircular canalolithiasis was confirmed. So this case is very important, and this case also points towards the shortcoming of the Berenice Society criteria. The Berenice Society criteria were applied on the day 1. Both Dix-Hallpike as well as the half Dix-Hallpike test shows right torsional upbeating positional nystagmus of more than 1 minute duration, and with a positive inversion test, the half Dix-Hallpike with positive inversion test was the first video of this patient. And now you again see a persistent upbeating right torsional positional nystagmus in the right half Dix-Hallpike position, but with a negative inversion test. So on day one, the persistent upbeating right torsional positional nystagmus during the half Dix-Hallpike test was because of the right posterior semicircular cupulolithiasis, which after two interventions was resulting in right short arm posterior semicircular canalolithiasis, again evoking a persistent right torsional upbeating positional nystagmus, but this time with a negative inversion test. So that's why the inversion test needs to be included in the Barani Society criteria, because we need to differentiate the two conditions. Why inversion test is negative during the half Dix-Hallpike test in short arm posterior semicircular canalolithiasis? This is the long sitting position. Right half Dix-Hallpike position, the otogonal debris is on the short arm side, pressing upon the posterior cupula of the right side and resulting in the ampulofugal persistent deflection, leading to upbeating right torsional positional nystagmus of more than a minute duration. And in the inversion position, that is the left lateral recumbent with nose down, the otogonal debris, it falls away and there is no cupular deflection, and then nystagmus disappears as you saw in the previous video. We carried out the prone pitch and yaw maneuver in this patient. Again with the head out and the vertex facing the ground, the head was shaken side to side 30 degrees at 3 cycles per second for 1 minute. So forwarding it to 1 minute. After which the static positioning with the vertex facing towards the earth was maintained for another 1 minute. And finally the patient was uprighted, completing the prone pitch and yaw maneuver. How this works is shown in a figure with animation. This is the otoconal debris here in the short arm of the right posterior semicircular canal, which is free floating. In the prone pitch and yaw maneuver, the otoconal debris, you see the labyrinth of the right side in the figure B. The otoconal debris was here initially. The repositioning brought it towards the utricle and it got embedded when the static head positioning was done. And finally, as the patient is uprighted, the otoconal debris is where it should be supposed to be. Right Dix-Hallpike retest was done 24 hours after the prone pitch and yaw maneuver, that is the adapted prone pitch and yaw maneuver, where that we call the dorsala prone pitch and yaw maneuver. Right Dix-Hallpike test during 1 minute of head hanging was absolutely normal with the static eyes. So this is not over because we need to augment it to half Dix-Hallpike position if we don't observe a nystagmus for full 1 minute. So in the next step, we anti-flex the head from the present right Dix-Hallpike position 60 degrees so that the head came 30 degree above the horizon. We looked for oculomotor response for 30 seconds in the right half Dix-Hallpike test with augmentation, and then we uprighted the patient to look for oculomotor response for another 30 seconds. In neither of the two, we could observe any nystagmus. It is almost 3 months as of now. The patient was followed up with telephonic interviews for 1 month and was given an open appointment, and she has not reported since then. She continues to remain asymptomatic at the time of presentation. So our final diagnosis is the odyssey of an otoconal debris, which was initial adherent on the canal side of the right posterior semicircular cupula, resulting in right posterior semicircular cupulolithiasis of the long arm side. That was successfully managed with the Bascule maneuver that transformed into the right typical periampullary posterior semicircular canalolithiasis. That was treated with the right Applet maneuver, but still there was a residual dizziness that we proved to be because of the right short arm posterior semicircular canalolithiasis, and that was treated with the adapted Dorasala prone pitch and yaw maneuver. And finally, the otoconia was repositioned back and his odyssey finished. Case 3 is right short arm posterior semicircular canalolithiasis. This is a 47-year-old female with positionally triggered vertigo for past 7 days. The left Dix-Hallpike test during 1 minute of observation did not evoke any nystagmus. But the patient is dizzy. So, as is our protocol, after observing the left Dix-Hallpike head hanging position with no oculomotor response, we carried out anti-flexion of the cervical spine to 60 degrees to bring the head 30 degrees above the horizon, and thus making it a left half Dix-Hallpike test with augmentation. Immediately on carrying out the left half Dix-Hallpike test with augmentation, there is appearance of left torsional upbeating positional nystagmus. So again, this could be either because of left posterior semicircular cupulolithiasis or left arm posterior semicircular canalolithiasis. We uprighted the patient from the current left half Dix-Hallpike position after 1 minute of observation, and still the left torsional upbeating positional nystagmus was present in the uprighting the patient from the present position. Later on, we carried out a half Dix-Hallpike test which was negative, and we treated this patient as a case of left short arm posterior semicircular canalolithiasis. You can see that on uprighting the patient from the left half Dix-Hallpike position, a persistent left torsional upbeating positional nystagmus is still present. If we had not done the inversion test, we would not have been very sure about this. We carried out the prone pitch and yaw maneuver, which is shown here with the clip speed increased by 3 times. 1 minute head shaking, fast forwarding it, and then static positioning with the vertex oriented towards the earth for another 1 minute. And then the patient was uprighted, completing the prone pitch and yaw maneuver. Next day, to our surprise, the lab Dix-Hallpike test oculomotor response were surprising. Left Dix-Hallpike test shows a 20 to 30-second left torsional upbeating typical crescendo decrescendo position nystagmus. So now it is a Other way around, from the short arm to the long arm posterior semicircular canalolithiasis, that is the intracanal migration of the otoconal debris, which was initially in the short arm of the left posterior semicircular canal, migrated following the prone pitch and yaw maneuver into the long arm that we treated successfully with the left apply maneuver. How did this occur? The otoconal debris you see here is in the short arm of the left posterior semicircular canal. In the prone pitch and yaw maneuver, the otoconal debris, instead of reaching the utricular macula, it went the wrong way into the common crus, and as the patient was uprighted, this patient had transition to left periampullary posterior semicircular canalolithiasis. So that's how the short arm posterior semicircular canalolithiasis by the intracannular migration of the debris from the short arm via the common crus reaches the typical periampullary posterior semicircular canal BPPV. Interestingly, the patient returned next day also. The video I have not shown here because this presentation would have become quite long. She had a cupulolithiasis of the right horizontal semicircular canal that was treated with the Zuma maneuver. So this patient had a multi-canal BPPV involving the left short arm posterior semicircular canalolithiasis that was treated with the prone pitch and yaw maneuver, and that resulted in conversion to the left long arm posterior semicircular canalolithiasis of the typical periampullary type. And on day 3, she had a oculomotor response that suggested the right horizontal semicircular cupulolithiasis that was treated successfully with the Zuma maneuver. Case 4 is the short arm side left posterior semicircular cupulolithiasis. This is a 62-year-old doctor. A day before, on 9 January 2024, she was treated with left apply maneuver. I went to her house and treated with the left apply maneuver. Next day, she returns with sitting up vertigo. Left Dix-Hallpike test, no nystagmus. So I was a bit perplexed. What has happened? The left Dix-Hallpike head hanging position was maintained for full 1 minute. I could not see any persistent oculomotor response that can be classified as nystagmus. So, as I had developed this protocol of anti-flexing the cervical spine 60 degrees if I don't observe a nystagmus in the head hanging Dix-Hallpike position, the next thing that I did was cervical anti-flexion from the current left Dix-Hallpike position. And immediately on left half Dix-Hallpike testing with augmentation, there occurs onset of a left torsional upbeating positional nystagmus that lasted for more than a minute. So it evokes a persistent left torsional upbeat positional nystagmus in the half Dix-Hallpike test with augmentation. And once the 1 minute elapses, it would be mandatory to carry out an inversion test to prove or disprove it to be left posterior semicircular cupulolithiasis. If in the inversion position, the nystagmus, left torsional upbeating and persistent that you see right now on your screen should become downbeating and right torsional. So the inversion test was done from left augmented half Dix-Hallpike position, right lateral recumbency with nose down, evokes or changes the nystagmus to be downbeating, and with the upper corner poles of both eyes torsionally beating to the patient's right. So, a left torsional persistent upbeating positional nystagmus in the left half Dix-Hallpike test that changes to right torsional and downbeating in right lateral recumbency with nose down is a positive inversion test suggestive of left posterior semicircular cupulolithiasis. The patient was treated with the Bascule maneuver. How did the evolution of posterior semicircular canalolithiasis to cupulolithiasis occurred after the Apply maneuver? Initially, the otoconal debris it went into the periampullary location from the utricular macula, as you see here by this animation. While the patient was repositioned with Apply maneuver a day earlier at her house, the otoconal debris, instead of getting embedded into the utricular macula, got onto the short arm side and got adherent on the short arm side of the left posterior cupula, and that resulted in left posterior semicircular cupulolithiasis. We carried out the Bascule maneuver, and 4 hours later, we tested her again. The augmented half Dix-Hallpike test at this time showed a very subtle left torsional upbeating nystagmus. It is so subtle that if you don't see it regularly with your open eyes without blinking, you will miss it. But there is a definite upbeating left torsional positional nystagmus. This was non-persistent. So even if it is non-persistent, in this case, I would like to do an inversion test to look for the oculomotor response in the inversion position. Inversion test was also again done after right lateral recumbent with nose down. There are no oculomotor responses in the inversion position. So this patient has now transformed from left posterior semicircular cupulolithiasis of the short arm side into the short arm posterior semicircular canalolithiasis post Bascule maneuver. The inertial forces generated during the Bascule maneuver disengaged the otoconal debris adherent on the short arm side of the left posterior cupula. And that's why the inversion test is now negative. We carried out the prone pitch and yaw maneuver in this patient, but that did not work here. So what happened after the Bascule maneuver is the otoconal debris was here. After the Bascule maneuver, it got disengaged. So the prone pitch and yaw maneuver was prescribed on the domiciliary basis. Her son was, who is a doctor, was taught to do the prone pitch and yaw maneuver, and after 2 days she was symptom free, and it is almost 2.5 years now. She continues to remain asymptomatic. There is a publication from Hermat et al. In 2022. Hypothetical mechanism of positional downbeat nystagmus in posterior semicircular cupulolithiasis or short-arm posterior semicircular canalolithiasis following typical posterior semicircular canal BPPV. The Dix-Hallpike position inferiorly positioned debris loads and deflects the cupula ampulopeterally. Arrow is shown here in this diagram. This hypothesis explains the downbeat nystagmus observed in 19 cases during the repeated Dix-Hallpike testing after the Apply maneuver for posterior semicircular canalolithiasis. However, our research group do not agree with such a hypothesis, because if you do a Dix-Hallpike test in a patient with posterior semicircular canalolithiasis of the short arm side, the otoconal debris will fall away from the posterior cupula into the short arm or directly into the utricle, and there would be no nystagmus. Possibly the downbeat contratorsional nystagmus observed by the Hermat in their case series of 2022 could be because of development of apogeotropic posterior semicircular canal BPPV post Appleman. We do agree that the rising to sitting position from Dix-Hallpike test, the otoconal debris on the utricular side deflects the cupula amplifugally under the gravitational inertial force, as shown in the arrow, and this is in line with our observations and that of Scocco. However, we agree with the Scocco 2022 publications in posterior semicircular cupulolithiasis. The oculomotor response during the Dix-Hallpike test depends on the posterior cupula shape and the acting gravitational vector. Say, for example, a right posterior cupula, which is shown here, which is a neutral cupula, during the right Dix-Hallpike test will not be deflected and there would not be any positional nystagmus. A canal angulated cupula during the right Dix-Hallpike test, this is the right posterior cupula which is canal angulated. During the right Dix-Hallpike test will evoke a left torsional downbeating positional nystagmus because there would be an inhibitory deflection of the right posterior cupula. A vestibulum angulated right posterior cupula during the right Dix-Hallpike test would evoke a persistent right torsional upbeating positional nystagmus with a positive inversion test. So the optimal positional test for evaluating positional nystagmus of posterior semicircular cupulolithiasis, and we add here also over and above the Barony Society criteria. Short arm posterior semicircular canalolithiasis is the half Dix-Hallpike test in conjunction with inversion test. Again, for your revision, the Dix-Hallpike test in short arm posterior semicircular canalolithiasis, the posterior cupula is parallel to the Earth's gravity, no positional nystagmus. In the half Dix-Hallpike test, it is orthogonal to the Earth's gravity and you see a upbeating ipsitorsional positional nystagmus. Why inversion test is negative in half Dix-Hallpike manner in the short arm posterior semicircular canalolithiasis is shown here again. Long sitting position, left half Dix-Hallpike position, you see a left torsional upbeating positional nystagmus for more than a minute. And during the inversion position, that is right little recumbent with nose down, the otoconia fall away and there is no pupillar deflection and therefore the inversion test is negative. Inversion test is positive during the half Hallpike maneuver in posterior semicircular cupulolithiasis. This is left here because there is a excitatory ampulofugal deflection of the left posterior cupula resulting in persistent left torsional upbeating positional nystagmus of more than 1 minute duration. In the inversion position, that is the right lateral recumbent with nose down, the left posterior cupula deflects ampulopetally, that is a inhibitory deflection that would result in a downbeating nystagmus, and that nystagmus in that case would be downbeating and right torsional. Case 5 is a very interesting case where we could pick up a left long and short arm posterior semicircular canalolithiasis in one single positional test. This is a lady in her mid 40s, came with the history of vertigo for past 7 days as well as sitting up vertigo. She also had a left Dix-Hallpike test after a short latency shows a 10-second typical crescendo decrescendo positional nystagmus, upbeating left torsional. So that suggested left periampullary posterior semicircular canalolithiasis. I don't know what prompted me to carry out head anteflexion to 60 degrees after vanishing of the initial nystagmus, and this now reoccurs a stronger left torsional positional nystagmus lasting for less than a minute. So I suspected a left short arm posterior semicircular canalolithiasis as well as a left long arm posterior semicircular canalolithiasis in this patient. The inversion test was predictably negative. We could not evoke any nystagmus in the inversion position, that is right little recumbent with nose down. We treated the patient with the left apple maneuver on day 1 and carried out a prone pitch and yaw maneuver, but the patient did not respond on the day 1. So she was taught to do the prone pitch and yaw maneuver for 1 week and we examined her after 1 week. In fact, she was being treated with the Bascule manual on the domiciliary basis. The left Dix-Hallpike test after 1 week was negative. We could not observe any oculomotor response during 1 minute of left Dix-Hallpike head hanging position. The patient was asymptomatic at the time of carrying out the left Dix-Hallpike test, and after 1 minute of negativity of left Dix-Hallpike test in evoking any oculomotor response, we carried out the cervical anteflexion of 60 degrees and thus making it a half Dix-Hallpike test with augmentation. Left half Dix-Hallpike test, that is retest after 7 days of Bascule manual, was also negative with no evoked oculomotor response. Patient was asymptomatic and it is almost 6 months now. She continues to remain asymptomatic. She was given an open appointment to report whenever the recurrence of positional vertigo occurs. So the extended spectrum of the type 2 BPPV, the typical posterior semicircular canalolithiasis is shown here. Many cases are associated with or get converted into it by residual dizziness is because of the short arm posterior semicircular canalolithiasis. The two may be present together. Many cases of the short arm posterior semicircular canalolithiasis may get converted into the posterior semicircular cupulolithiasis or may get coexist with it as shown by the Scocco in 2022, and sometimes the type 2 BPPV, that is the short arm posterior semicircular canalolithiasis, may get converted to posterior semicircular cupulolithiasis. Short arm posterior semicircular canalolithiasis associations. It may be associated with typical posterior semicircular canalolithiasis that we saw in the last, that is the fifth case we discussed in this presentation. It may be associated with posterior semicircular cupulolithiasis. 11 out of 18 patients in the Scocco 2022 series were having a concurrent posterior semicircular cupulolithiasis. It may be associated with the horizontal semicircular cupulolithiasis in the case that got transformed from the short arm to the long arm posterior semicircular canalolithiasis of the left side that I demonstrated in the presentation also had a associated right-sided horizontal semicircular cupulolithiasis. It may also be associated with horizontal semicircular canalolithiasis, a possible autocorrected case that was the first case of this presentation. However, the typical posterior semicircular canalolithiasis may get converted into the short arm posterior semicircular canalolithiasis, resulting in the residual dizziness that we saw in one of the cases, that of otoconal odal C. The short arm posterior semicircular canalolithiasis may also get converted into the posterior semicircular cupulolithiasis. Summing up, the core clinical features remains the same that was described by Bela Buki as subjective BPPV, that is a sitting up vertigo, non-positional disequilibrium, no nystagmus on positional test till 2022. But now we have positional nystagmus on the auxiliary positional test, abnormal truncal, diagonal, anterior-posterior oscillations during and after sitting up. What are the additions in the recent times? Half Dix-Hallpike test may show upbeating ipsitorsional nystagmus of more than 60 seconds with negative inversion test. Some of these cases may have upbeating ipsitorsional nystagmus on getting up from the lateralized Dix-Hallpike position or during the augmented half Dix-Hallpike test described by G. Sukim in year 2024. Many of these cases may have a half Dix-Hallpike test showing upbeating ipsitorsional position nystagmus of more than 60 seconds with positive inversion test. So the short-term posterior semicircular canalolithiasis is occurring concurrently with posterior semicircular cupulolithiasis. And in such cases also, you see a upbeating ipsitorsional nystagmus evoked on getting up from the lateralized Dix-Hallpike position. So that does not make a difference from the short-term posterior semicircular canalolithiasis, and that's why carrying out a half Dix-Hallpike test with augmentation in conjunction with the inversion test is mandatory. Many of these cases of the short-term posterior semicircular canalolithiasis may be associated with typical posterior semicircular canalolithiasis, and the two are interchangeable that we have demonstrated in our cases. So all maneuvers to remove the otoconia from short arm into the utricle are based on bowing down as you pray while doing the prayer. The otoconal debris moves towards the utricle and it gets embedded into the utricular macula. The part B of my talk is the sitting up vertigo because of periampullary located posterior semicircular canalolithiasis that was described by Scocco in 2019. This is a 62-year-old male patient who came with the history of positionally triggered vertigo for 7 days. The initial left Dix-Hallpike test did not evoke any positional nystagmus. During 1 minute of observation, this patient was seen by me in year 2023. At that time, the augmented half Dix-Hallpike test by G. Sukim was not reported. But since then, I have made it a point to observe the oculomotor response on getting up from the Dix-Hallpike position if I don't see any nystagmus during 1 minute of observation. So as the patient was uprighted from the left Dix-Hallpike position, after a latency of 10 seconds, there was a persistent left torsional upbeating positional nystagmus. Here it starts, left torsional upbeating positional nystagmus. I observed this for full 70 seconds and then labeled it as persistent left torsional upbeating positional nystagmus on sitting up from the left Dix-Hallpike test. I also carried out a half Dix-Hallpike test by yawing the head 45 degree to his left and positioning him supine with the head landing on a 4-inch thick pillow and anti-flexing the cervical spine around 30 degrees to make it a half Dix-Hallpike test done in conventional manner. Left half Dix-Hallpike test, which I just narrated, did not evoke any positional nystagmus. The 45-degree yawed head to the left lands on a 4-inch thick pillow and gets anti-flex 30 degrees and thus making it a traditional left Dix-Hallpike test. During 1 minute of observation, I could not observe any nystagmus. So I still thought this as a left short arm posterior semicircular canalolithiasis, and at that time the only maneuver which was known to me was Buki's maneuver, that is carrying out the multiple sit-ups from the lateralized left Dix-Hallpike position. That I did. Head hanging Dix-Hallpike position for 5 seconds, and then again uprighting, and then again 10 times I did, twice on day 1, and called the patient for review after 24 hours. The next day patient returns and I carried out a left Dix-Hallpike test, and to my surprise it evokes a typical crescendo decrescendo left torsional upbeating positional nystagmus, and this patient now has a typical periampullary posterior semicircular canalolithiasis. So inertial forces generated by the repeated sit-ups in a patient with periampullary posterior semicircular canalolithiasis with partial canalith jam, sitting Dix-Hallpike, then sitting, then Dix-Hallpike. That was left side sitting to left Dix-Hallpike, and then again sitting. They created the inertial forces. The otoconal debris was big here, but here the canal diameter was narrow. And as I carried out the multiple Dix-Hallpike testing and multiple sit-ups from the left Dix-Hallpike testing, the otoconal debris crumpled and it partial canal jam got cleared, and that's how it resulted in the typical posterior semicircular canalolithiasis conversion. So first negative inertia, ampulopetal movement of the debris occurs. This is the explanation by 2019 Scocco variant, but there is no positional nystagmus. The free-floating otoconal debris in the descending periampullary posterior semicircular canal encounters an ampliofugal restriction of its movement during Dix-Hallpike test, either a large debris size or an anatomical reduction in the diameter of the semicircular canal, creating a partial canalith jam. Thank you very much. I finished my talk here.